Good morning, everyone. My name is Megan Chung. I'm a medical student at Columbia University, and it's my honor today to share our work on technical complications in aortic root replacement. Aortic root replacement remains a complex procedure with many possible adverse intraoperative events, such as coronary events, massive bleeding, unsatisfactory appearance of the aortic valve during aortic valve repair. We currently have a limited understanding of the frequency of these intraoperative complications, and as such, we sought to comprehensively describe the incidence, causes, and impact of various technical events during aortic root replacement. We propose this term technical events and its definition as such as any of the following intraoperative events: need for additional aortic cross-clamping, intraoperative conversion from valve sparing to composite valve graft procedure, requirement of an unplanned cardiac procedure including emergent CABG, mitral valve procedure, aortic arch repair, and need for mechanical circulatory support including ECMO and balloon pump and Impella. We then further categorize these technical events into one of 5 causes based on their predominant intraoperative complication for descriptive purposes. We looked at all aortic root replacements over the span of 10 years at our center. We retrospectively reviewed the medical record, and we used logistic regression to analyze factors associated with technical events and the in-hospital outcomes of operative mortality and major postoperative complications, which we defined as any of the following during the hospital stay: re-exploration for bleeding, stroke, prolonged ventilation, and acute kidney injury. In this data set of 830 aortic root replacements, technical events as we defined it occurred in 90 or 10.8%. And were as follows: the most common being bleeding requiring additional cross-clamp and rearrest of the heart in 26 cases. This occurred at the aortic suture line in 11 cases, in the coronary button in 9 cases, and other sources of refractory bleeding included the main PA, the right atrium, and the right superior pulmonary vein. The second most common cause in our data set was non-ischemic ventricular dysfunction requiring MCS to wean off bypass. This required an additional cross-clamp in 1 case. We used ECMO in 15 cases and balloon pump in 7. Next, residual valve disease was seen in 20 cases, requiring additional cross-clamp in 16. There were 8 intraoperative conversions from valve sparing root replacement to CVG procedure. There were 5 re-repairs of the aortic valve in a valve sparing root replacement, 5 mitral procedures, and 2 aortic valve re-replacements. We had myocardial ischemia in 19 cases, requiring additional cross-clamp in 13. There was an unplanned CABG in 18, including 10 to the right, 7 to the left, and 11 to both coronary systems. And we needed MCS in 5 cases. And lastly, there were 2 iatrogenic dissections requiring a distal extension to replace the arch unexpectedly. Looking at the patient's baseline characteristics separated by patients with and without technical events, they were similar other than an increased incidence of prior sternotomy, urgent or emergent indication, and surgical indications of dissection of aortic valve disease in the technical events cohort. Looking at intraoperative details, the technical events cohort had a higher percentage of composite valve graft procedures as planned, as well as concomitant valve procedures. Understandably, this cohort had longer procedural times, and you can see the distribution of technical events in this table as well. When we ran a multivariable analysis of preoperative and intraoperative factors associated with technical events, we found that only prior sternotomy was significant predictor for technical events. Looking at our observed postoperative outcomes, the technical events cohort had a higher operative mortality, which was nearly tripled when compared to patients without technical events. And this cohort also had an increased rate of all major morbidity during the hospital stay, as well as a longer hospital stay. When we ran a logistic regression to see variables associated with the composite outcome of operative mortality and major postoperative complications, we found that in combination with other baseline characteristics and the surgical indication of dissection, that technical events independent of bypass time were associated with the outcome. When looking at variables associated with operative mortality, we found that surgical indications of dissection and aortic valve disease, but not technical events, were associated in this data set. This was a single-center retrospective study with a low event rate of technical events and observed outcomes. Perhaps our largest limitations was that we developed our own definition of technical events, which certainly has room for improvement. For example, significant intraoperative bleeding that did not require additional cross-clamp was not counted in our definition. Postoperative MCS could be required for non-technical reasons, for example, poor ventricle preoperatively. Quality of aortic valve repair during valve-sparing root replacement was not taken into consideration unless another aortic cross-clamp was needed. As such, there's a need for future studies to refine definition and guide the management of these cases. In summary, technical events occurred in 10.8% of aortic root replacements at our institution, the most common causes being bleeding, non-ischemic ventricular dysfunction, MI, and residual valve disease. Reoperative sternotomy was the only variable found to be associated with technical events, and technical events were associated with in-hospital morbidity, but not operative mortality. Thank you very much.